That's great. Thanks so much, Rena. Welcome everyone to our webinar today. I'm David Willis, founder of Nurture Connection, and I'll be your moderator for this exciting gathering today. And I want to give special thank you to the Early Childhood Funders Collaborative, the Early Relational Health Funders community, and of course our teams within Nurture Connection. Nurture Connection is an impact network, and in collaboration with Health Connect One, and we conducted a 2-year project that was funded by the Pritzker Children's Initiative, the W.K. Kellogg Foundation, and the Burke Foundation. This was a learning journey where we focused on enhancing the Health Connect One doula curriculum about the doula's role in supporting early relational health between birthing people and their babies. Today, you're going to get a chance to hear from a series of panelists who have been closely involved with the project and who will bring reflections on this good work. And we only have an hour for our time together, and so I'll introduce each panelist as we go along today rather than at this moment. I want to encourage you to take a look and to review the bios that's on the announcement. So as we begin our dialogue, we'll welcome questions in the chat, which we'll attend to as we can over time. And if we're not able to attend to all the questions during the session, we will complete a FAQ that'll be connected to the recorded session that'll be on our website. So let's get started. I first asked Andrea Palmer, who's program officer with the Pritzker Children's Initiative, to bring her brief remarks about why the three funders came together in support of this project. So Andrea, can I come to you?
Thank you so much, David. I think that as the early childhood funder, I can speak particularly about the Pritzker Children's Initiative. And when we think about the fact that a child, if our goal is for children to flourish and thrive, and we think about them within the context of their family and the context of the community, then it's really important to be able to support that relationship between the mom and the baby. And again, with the relationship-based programs, such as the support that doulas provide to mothers, they made absolute sense that we would incorporate them into the workforce that is helping to support that mother and child relationship. So I think that was like one of the leading reasons that we chose to fund this project.
That's great, Andrea. And again, we're very thankful to your friends at Kellogg as well as the Burke Foundation for likewise coming together in supporting us. So let me turn now to my friend and colleague, Hoda Shalki, who's a clinical nurse practitioner and a maternal child health equity consultant, who can share with you about the co-design process and the learning of our teams of Nurture Connection with the Health Connect One. So Hoda, to you, please.
Great. Thank you, David. So the purpose of this 2-year project was to adopt a training that would enhance the early relational skills, as Andrea mentioned, across Health Connect One's doula and perinatal support networks. So during year 1, Health Connect One outreach to partners across the nation who'd be interested in piloting the curriculum. And in order to ensure that this curriculum was co-designed, informed, and driven by the community of doulas, we formed an advisory council, conducted key informant interviews, focus groups, as well as a national survey of community-based doulas, which many on this call participated in. Thank you. To understand the perspectives, approaches, and needs related to promoting early relational health by community-based doulas. So if you go to the next slide, please. From the more than 160 responses that we received, the survey respondents confirmed what we knew about community-based doula work, which was that it is very relational. So while doulas may not be calling it early relational health, 90% of the doulas who responded to the survey felt that the work that they do aligns with the core story definition of early relational health that we had provided in the survey. So we decided that the curriculum need not teach about strengthening relationships, because that's what community doulas already do, but rather it would enforce what the doulas already do. So the curriculum helped doulas to acknowledge the ancestral wisdoms, culturally centered practices, and their inherent ways of being that they use when working with families, and we connected those to the principles of early relational health. This helped the doulas to see themselves as a crucial part of the early relational health workforce and the social justice movement. So as we were co-designing this curriculum, we asked ourselves a very important question. While community-based doulas are doing so much to hold their communities, who was holding the doulas? So to address this, we infused into the curriculum experiences in which the doulas had the opportunity to see, hear, and hold one another in mutual support as peers. And then we piloted the curriculum. So 3 organizations participated in this cohort, in the first cohort during year 1, and based on their feedback, the curriculum was adapted in year 2 and offered to 3 more organizations, split into 2 more cohorts. And Dr. Twyla Dillion will speak about the outcomes and learnings from this project a little bit more, but first I'll pass it back to David.
Thanks so much, Hoda. That was really wonderful. And yes, Dr. Dillion, Twyla Dillion, who's the director of Health Connect One, I want you to join our conversation and share some of the evaluation and the curriculum changes and some of the key learnings and findings. So can I come to you, Twyla?
Of course. Thank you, David. So we had several different partners, as was shared already, across cohort 1 and 2. During cohort 1, we had a partner in South Carolina, Michigan, and Oklahoma, and in cohort 2, New Jersey and New York. So very different parts of the country, which really helped us to get a richer experience as we navigated through iterating the curriculum. We can go to the next slide, please. We go back up 1. Thank you. So the evaluation really wanted to focus on uptake, acceptability, and effectiveness. There were 4 key questions, which we'll go through now, so I won't read them. We can go to the next slide, please. Thank you. So the first question was, did the CBDs comprehend and accept the training curriculum? So over 50% agreed with the definition of early relational health. One thing we heard a lot was folks understood what it was, but hadn't called it by that name. So I think even the value of naming something and actually being able to use that as we navigate through the work is incredible, right? Folks didn't see themselves as that, but by the end, 100% identified themselves as part of the ERH workforce, knowing what that definition means. The next question was, how did the training impact the utilization of these ERH skills by community-based doulas? I think something that our doulas really appreciate is peer-to-peer learning. Our model is Ferrarian or popular education based. So the opportunity to really act out these scenarios elevated their acceptance and understanding of what it is they were learning and made them more confident and comfortable actually using these skills in community. They also reported using various components in their practice, which improved client relationships. I'd like to go to the next slide. I think that has some quotes that really concretize this. I think I'll just read one because you can read the other one. The most important thing is that the woman or the birthing person feels comfortable in the space. And I've also had to talk to patients with their partners around. So it's important to give space for the partner to also give their input and be part of the conversation, obviously with respect to the birthing person. So I really like the training because it works with so many facets of life. Community-based doulas don't just work with the birthing person, right? The non-birthing partner or husband, boyfriend, those are folks who are also incorporated into this work. So the early relational health model fits very well when we're working in communities with partners. We can go to the next slide, please. Did the training increase parental knowledge of early relational health among birthing families? So the doulas reported using various components in their practice, which helped to improve client relationships and personal and professional development. So the way that they were able to interact with their clients was enhanced by having these skills and also being able to use the language and some of the tools, which I'm going to talk about one in a moment, that came from the training. This positive outcomes observed among clients include enhanced interaction, better articulation of support needs. So folks are better able to call out places where they have gaps and community-based doulas can support them. And then increased understanding of their own personal circumstances, including their intergenerational experiences. We can go to the next slide, please. This is where I wanted to call out one of those tools. Mom was possibly a teen mom, and her mom was possibly a teen mom. So the community resilience tree, which is a metaphorical framework that represents interconnected elements required to build and sustain resilience in community, really allowed them to see or to reflect and figure out a better way that they can also help the young mom navigate through life, right? So being able to reflect back to see forward. We talked about the family dynamics. We all know that in Black and Brown communities, there's a lot more complexity than just mom and dad. There are other family members that play a very intricate part in upbringing of any child. So in our communities, this is so important to be able to look at things intergenerationally and figure out how we create a path forward. We can go to the next slide, please. And then the fourth question was, what additional resources and support are needed for community-based doulas to apply these skills effectively? The doulas identified challenges such as confidence in new skills, family resistance, right? There are a lot of challenges that our communities are facing, resource knowledge gaps, and specific tool-related difficulties. They highlighted the need for continuing education and peer support networks around this work. Recommendations for strengthening future training cohorts included adjusting the length of the curriculum and components, and then boosting confidence. I love hearing confidence over and over because that's going to come from practice, right? And establishing peer-to-peer reflective support networks, again, that can give that practice opportunity. So all in all, folks were generally really appreciative of the curriculum and increased awareness of what early relational health is and how it applies to their profession, and really craved more opportunities to receive continuing ed, as well as having a place to practice these skills. Next slide, please. All right, I'm going to pass it back to David. Thank you, everyone.
That's great, Twyla, that was fabulous. And, as we were moving along in the project, it became clear that there was an opportunity to articulate policy and the policy implications of this work. So we invited our dear friend Kay Johnson from the Johnson Policy Consulting Group, who's been a longtime friend, mentor, advisor, to help with this element of the project. As you know, Kay is an MCH luminary and has guided so much of the development of Nurture Connection's early relational policy agenda and our major manuscripts, including the release last April of this policy work that we entitled Community-Based Doulas and ERH, the Role of Public Policy and Financing. That can be found on our website. So Kay, can you share with us the perspective that we came together to learn?
Sure, absolutely. Delighted to be with you. And this gives a headline. This is our ERH policy goals. I don't have time to go into each element of it, but certainly this one touches on equity, provider training, services to promote early relational health, and building a relational workforce. This project touched on all of those, as well as the systems and some other issues. Next slide, please. So the approach of the report is very important to share with you. So we were not creating something new or trying to reinvent the wheel. And what I was well aware of, and many of you and who are participating today probably are, is that there are many reports with policy recommendations for doulas, and quite a number of organizations, including Health Connect, one that have written about this. So the report did an analysis that detailed where current policies fall short. So I worked on that with Hoda, who is a co-author of this report. And then we made recommendations based on both lessons from the project and a synthesis of the recommendations of others. And we did have reviews from leaders in the policy field, and Twyla Dillian, Amy Chen from the National Health Law Program in Help, and others such as NASHB gave us a review to make sure that we were representing their work well. Next slide, please. So we made recommendations in several areas. These will seem familiar to you. First, about increasing the use of Medicaid to finance doula services. As many of you know, I've worked for many years on how we finance various kinds of maternal, infant, and child health services using Medicaid. So we are encouraging states to use one of their options to reimburse for birth and community-based doula services. We're particularly advancing the idea that they should use the state plan amendment for preventive services, and that when they do that, they should clarify and simplify the rules, particularly saying that referral is not required. Next slide, please. We thinking about how do we increase the use of Medicaid to finance the services once it's covered. So setting sufficient and fair reimbursement rates, making sure expectations are in managed care contracts, thinking about the role of federally qualified health centers, and incentivizing the use of team-based maternal health care, which would include doulas. Next slide, please. The administrative mechanisms in Medicaid are often a barrier to people from various aspects of the workforce participating. So we're recommending that they provide administrative structures and technical assistance that support doulas if they're trying to be a Medicaid provider, particularly billing processes, and to align with other state requirements. Medicaid doesn't have to make up a bunch of new requirements or competencies for doula. They're probably already there in their state or in their workforce, and reimbursing both in-home and community settings, not just in a healthcare setting, and having the data to show impact. Next slide, please. We have a set of recommendations that would ensure ongoing training and supervision. I certainly learned more from this project and the work of Health Connect One, and talking to my co-author Hoda about this. How do we make sure that we're financing not only the direct service, but also the training and supervision? This may not come from a Medicaid dollar, but we want to ensure that the requirements for training and certification are not unnecessarily restrictive in Medicaid, so they're not having to do things that would be unnecessary without Medicaid being a payer. Supporting a variety of training programs, and we've identified in the report some potential sources of that, offering low cost and no cost and sliding scale, provide financing for reflective supervision and support, and to support to provide them in support and information that can grow a diverse doula workforce. So all in all, we feel very strongly that these are reiterations of many ideas in the field, and we're well supported by this project. Next slide, please. Back to you, David.
That's great, Kay. Phenomenal. And so you've heard about the project. You've heard about how it's put together. You've heard about some of the key learnings and the policy implications. And we want to have more of a conversation between our panelists. And first, I'd like to bring in some reflections from those that actually are in practice. And so we've asked first Cynthia Hayes, Project Director of the Doula Advocacy Team of Doulas for Connecticut Coalition. What does this report and this learnings mean for you and others around doula practice? Your thoughts. Welcome.
Hi, thank you, David. It's a pleasure to be here. I'll be very brief, but I can talk to you a little bit about what we're doing here in Connecticut and how we've become so successful and how we've been able to implement all of the practices that we discussed here that were most important. I think that first and foremost, when we're talking about the best way to support doulas and doula community programs, is to first and foremost, and this is something that we were able to do here in Connecticut, make sure that the doulas were centered in those conversations. And the reason for that being so important is because we needed to make sure that everyone had a profound understanding of the scope of the work, because it's often misunderstood what we do, how we do it, even why we do it, and the evidence that supports it. So we were able to meet with the medical community, local funders and organizations, and they were also able to provide certain platforms so that we can continue this discussion with all of the important players and in our community. We were also present for decisions concerning policy changes. State legislators started to become our biggest proponents. We even, from DC, our former Attorney General, now Senator Blumenthal, held a press conference on Juneteenth to talk about the collaboration and some of the successes that we were having here in Connecticut. Some of the other representatives, and I think they might be out there in the audience, definitely Representative Kai Belton, who I've just come to know, other representatives like Representative Robin Porter, Senator Anwar, State Representative Trenae McGee, have all helped us to move forward in legislation, very important legislation, so that we can get closer to certification and, as we've already heard mentioned, be able to tap into being reimbursed through our state Medicaid program here that we affectionately call Husky. Also, there was local support from March of Dimes, Health Equity Solutions. We also have Allison Logan on the call, and all of their work have been very instrumental in helping us to organize, create policies, and be able to just be there for the families here in Connecticut.
Cynthia, that's fabulous. The progress and the leadership and the vision of actions is really phenomenal. Hoda, can I turn to you also, because you're a practitioner. So what did this project mean to you in terms of how you think about this good work?
Thanks, Dave. I think I like to always take it from a relational and personal level. I think that when clinicians, whether it's clinicians or whether it's doulas, I think I take this back to my thinking as what it feels like to be a practitioner in the clinic. And if only health systems can emulate what doulas are doing in terms of accepting mutual support and really uniting together, because when you feel more whole as a provider, you can provide more holistic care. And I think we have a lot as a healthcare system to learn from the community of doulas.
Such a strong, strong point. That's really important. I wonder what the experience of this project means for training. And as we move forward, Twyla, what do you take from this project in terms of future training and within Health Connect One?
Thank you, David. I think for me, we're doing a lot of work at a national level to bring together all sorts of different community-based doula training organizations. The fact that this training has already occurred and we've seen wonderful outcomes from it, providing continuing education to enhance and grow some of the skills that doulas already have, including their awareness of what early relational health is, the tools that are in the toolkit that they can use as they're navigating different families, because there's so many different kinds of families, so many different kinds of dynamics. This just gives them an additional tool set that they can use when they're working with families, and also an environment where they're learning together. I think the model of training that Health Connect One uses and many partners use is really this very heavily relational model, right? We're learning from the people in front of us, as well as conveying some of the vital skills that they need to support families. So that's something else that can come from this. When we do our trainings, it's in a cohort from different organizations. So everyone's learning from each other, bringing up past experiences, and really being able to test out some of what they've learned. What was shared around having those peer-to-peer networks, I think that's something for us to consider, something that's very important for us to consider, because like speaking another language, you really have to practice to be good at it. And I think that that's something that could really come out of this. Additional training through continuing education, as well as growing a peer support network around the work.
That's phenomenal, Twyla. I have to add, from the Nurture Connections viewpoint, what has been speaking to me and to others is the learning that doulas, as they enter the first level of a relationship with families, often share their own birth story, their own narrative, their own entering the relationship with sharing their own intimate story as a way to engage and connect. I think that's incredibly powerful, self-evident, but powerful in the way of partnering and engaging families. The second thing that I've taken from the project thus far that I share across the Nurture Connection Network is the power of narrative and the power of sharing stories with one another as a way to connect, as a way to grow, as a way to inspire, and as a way to learn that as an individual, I can grow by sharing my experience with others. So from a nurture connection standpoint and from the relational health standpoint, these sharing intimately of the stories of personal experiences connect people, but also serve the function of growth, healing, and development, which I think is really powerful and important to carry far further across our network. Well, the third reflection question that's come up to me is important around the Healthy Start communities. And many know Maternal Child Health Bureau is invested in communities to improve health outcomes during or before, during, and after pregnancy for a number of decades, and with the Healthy Steps, and with Healthy Start. And we've invited Dana West, who's a project director for the Department of Health Equity Innovation at NICHQ, the National Institute of Child Health Quality, asking that question: what do these learnings mean for Healthy Start? So to you, Dana.
Yeah, thank you, David. I want to just briefly provide like the purpose of the Healthy Start program, in that it is to improve health outcomes before, during, and after pregnancy, and reduce racial ethnic differences in rates of infant death and adverse perinatal outcomes for folks on the line who may not be familiar. And it is funded through the Health and Resources Services Administration, Maternal and Child Health Bureau. So the relevant supplement related to doulas is to increase the availability of doulas in Healthy Start service areas, right? Most affected by infant and maternal mortality, to reduce deaths and decrease racial and ethnic disparities. So doulas in these particular areas are those community-based organizations that were funded, will provide services to women during pregnancy, birth, and 3 months postpartum. So the funding provided to these organizations is intended to cover training, certification, and compensation of doulas. So for the Supporting Healthy Start Performance Project and the Healthy Start Technical Assistance and Support Center, which is TASC, that I am project director, serving as interim project director on, we provide training and technical assistance to grantees to improve their service delivery, meeting outcome measures, and building program ability to work with community partners and to improve health and social services to reduce maternal and infant health disparities. And so just for a little clarity, there are 105 Healthy Start Initiative grantees that are working to reduce infant mortality rates in their catchment areas and to decrease disparities of infant mortality and poor perinatal health outcomes. We also provide support to Catalyst for Infant Health Equity Project award recipients, and they are expected to implement action plans to apply data-driven policy and innovative system strategies to reduce infant mortality disparities and prevent excess infant deaths. And lastly, we also support a Healthy Start enhancement supplement for Healthy Start grantees. Of course, I'm saying it sounds a little repetitive, but they are all working to improve health outcomes before, during, and after pregnancy, using well-documented racial ethnic differences in rates of infant death and adverse perinatal outcomes. So while we have not received many, hardly any requests for technical assistance or training specific to collaborating with or incorporating doulas into providing direct and enabling services, for example, like screenings and referrals, case management, care coordination, health and parenting education, and linkages, excuse me, to other clinical care. We are like prepared to do so, right? So we provide group-based prenatal, postpartum health and parenting education support through subject matter experts. Some of them are nationally recognized with primary expertise in preventive health, community-based resources, breastfeeding, infant care, parenting, community advocacy, social justice, and some of which are midwives and doulas. So we also provide group-based education and opportunities for grantees to engage with networks, which would and could include additional doulas. So we have a full understanding of the impact of including doula services in pregnancy, birthing, and postpartum experiences and making this connection. So much so that it is prudent that we provide a support in facilitating this connection. So I think we have, as a part of our Healthy Start enhancement grantees, we will be reviewing their action plans to improve health outcomes before, during, and after pregnancy, and reducing like well-documented racial ethnic differences in rates of infant death and adverse perinatal outcomes. So we're expecting that we will be providing direct support and guidance regarding evidence-based models, best practices, and now we would be able to inform this support from the findings of the early relational health assessment and toolkit, especially given the home visiting component of many of the Healthy Start grantees, where this early relational connection can certainly begin. So it is an opportunity for sure to get in there and facilitate and support and nurture this connection between Healthy Start grantee participants and providing guidance to project directors and folks who are working on within these Healthy Start grantee programs in the nation. So we are here and we are ready. And also I want to say, just in reviewing the results of the assessment, we can certainly be proactive rather than reactive and waiting for folks to reach out to us to ask for support, but putting together perhaps a webinar or training for the larger group of grantees to just understand these findings and how they can impact the work that they're already doing. So this is wonderful information, and just thinking through, as I'm talking, additional ways that we can move this information forward across our grantees. So thank you.
Dana, that feels like an expanding partnership opportunity. Let's explore that
Indeed,
further.
indeed.
Indeed, and Kay, you've been a long-standing champion and advocate around Healthy Start. I'm curious how what your thoughts are again from the founding of this experience with Health Connect One and Nurture Connection, early relational health, and the Doula experience that we are documenting here. What jumps out to you?
Well, a couple of things. I just want to augment a little what we just heard from Dana. And first of all, to say that the NICHQ TA Center really has brought an extraordinary amount of resources and clarity and support to Healthy Start grantees all over the country. I was there in the Rose Garden in 1991, the day that President George Herbert Walker Bush announced that he wanted to go to communities with high rates of infant mortality with direct support. I was the co-chair of the coalition that got the legislation passed and that got the first appropriation for Healthy Start. And I've been a champion of the program since it grew from those 15 sites all the way to the more than 100 sites we've had in recent years. I see it as the nation clamoring, and particularly in our field and the circles that most of us travel in, clamoring for community-based solutions that are about serving the Black and Indigenous women who have the highest maternal mortality rates. Healthy Start is the only federally funded program that is designed to do that. The Maternal and Child Health Bureau, very wisely, and Congress supporting, made resources available to really try to accelerate the role of doulas in those 100+ communities. But it's only a portion of the communities. In addition to that, I'm going to get a little political in saying the current House appropriations language would zero out Healthy Start, 145 million, zero it out altogether. It makes the program go away. Somehow they got the idea that it was duplicative. If you want to know more about that, you can write to me or offline, or you can go to the Healthy Start Association or the AmChip website and find out more about that. These communities are about the solutions that reflect the culture, the decision-making, and really the needs of pregnant women and birthing people in their communities. Because they are in the sites with 1.5 times the national average infant mortality rate, they are virtually all in communities with a high concentration of Black and Indigenous women. There were 147,000 women out of the 85,000 participants, 147 women plus double it for the babies, right? And 75% of them were Black and brown women. This is a way that we can infuse the work of doulas into the highest needs communities. And I think the messages that we have here can bring those resources forward. It is also an opportunity to demonstrate what it looks like to bring doulas into a team. One of the projects that I've done in Healthy Start talked about the team-based approaches really in the community work. So community health workers, peer outreach workers, other peer outreach workers, tiering up to maybe a social worker or a nurse where there's a particular medical or psychosocial need, and figuring out how a community action network brings community-wide strategies together. Doulas should be a part of that picture in every Healthy Start site, and I hope that we can get the resources, training, and connections to make that happen. Back
Thanks,
to you,
Kay.
David.
Yes, that's great. great conversation from a lot of various yet committed perspectives. And I'm really thankful for that. I welcome those that have been listening to put questions into the chat, please, into the Q&A, and we will attempt to answer them. And we welcome reflections from not only those from the funders community, but also across the Nurture Connection Network or others. So please add those too, and we'll respond to them. But first, Andrea, I wonder if you could give us your reflections from a funder's perspective.
Sure. I think that, we were really interested as the project advanced, and really excited to learn that when you talk to the doulas, they actually thought that early relational health was a skill and a tool that they were already using. And so that made it more important to us that you all pivot and think about the policy implications, think about how doulas are then funded to support that, really honing that skill and including it in their work. And we really viewed this as an opportunity to link maternal child health work with early childhood work. So I think that really sums up what the importance of this project to us.
Thanks so much, Andrea. Let me go to some of the questions that are here. One of the questions that's been coming forth is about rate setting and payment structures, and the movement, of course, to be successful in reimbursement structures and various approaches to that. And I wonder, some of you, I'm sure, have good thoughts about what's emergent, what's developing, and I wonder if we could have a little conversation here. Okay, do you want to start?
David, I'd like to start, and I'm sure that Twyla has some more ideas about this. And I guess the thing that I would say about it is framing that conversation is really important. So I'll just say, I was talking to someone about this yesterday in the context of doulas in particular. We can't just go to policymakers, whether they're in state agencies or in state legislatures, and say, you have to pay us cost, or you have to pay us fairly, or you have to pay us adequately, because the dirty little not so secret story in Medicaid is that they don't pay anyone cost, they don't pay anyone fairly, and they don't pay anyone adequately. So if you go to them with that, they're thinking in their mind, well, we don't pay the doctors, we don't pay the hospitals, we don't pay the psychiatrists, we don't pay anybody at full rate, we don't even pay people at the Medicare rate. So if you just go and say you're not paying us our costs, you're talking right past them. But the fairness argument, I think we can lean into. I think there is a lot of room, and Twyla can maybe say more about this, but there's a lot of room. States like to compare to one another. If everybody's paying $5 a visit, they're not going to be the first one to go out. We've got some leaders, and we can go, it worked in home visiting. You can go to the next state that's interested in this topic and say, well, these people are paying a solid rate that brings the workforce in, and it is fair compensation. Well, you might even add, it doesn't cover all of our costs, but is fair. So I think it's framing the conversation in a Medicaid way. Just saying it doesn't fully cover our costs doesn't work in Medicaid, because they don't cover anybody's costs, even the federally qualified health centers, where they're federally required to cover everybody's costs.
Good, strong, and critical point, Kay. Thank you for that reminder. But it's also the strategy of communication and keeping the focus on the fairness as well as the opportunity. Twyla, you have thoughts, I'm sure, maybe Cynthia?
So many thoughts. I'll try to keep it brief. I think one of the things that we're identifying with community-based doulas specifically around reimbursement is that the process, it's not even down to just the rate, the process is archaic. And it's also not the kind of process that should be expected by community-based providers. These are non-clinical providers. They're folks that don't work within hospital systems, and then we're expecting them to now also be billers. Many work independently, and even if they work in an organization, the process is too complex. This was something that we went on and on and on about in New Jersey, but it is something, when we were running the Dual Learning Collaborative, but it is something that really needs to be elevated to the point where states have guidelines around how they interface with community-based practitioners. In a perfect world, we have even more community-based providers because they're so much closer to community because they're a part of community, right? It's going to be hard to do that if our first go at it fails. And I honestly believe to my bones that if we don't have a new mechanism for how doulas that are doing this work are paid, it's going to be very hard to keep them in the profession. So I think that that's a strong statement, but one that I have learned time and time again as we've worked in other states, and I see the heart, so I know I'm not the only one thinking it. There's definitely an opportunity for improvement on how community-based doulas and community-based doula organizations are paid, not just if they're paid, how they're paid.
Strong point, Dola. So agree. Cynthia, what's been your experience and your thoughts about this, please?
Well, I'm so grateful for these perspectives. I mean, you all have been in the trenches for quite a while. We're still fairly new here in Connecticut, and we didn't know enough not to ask for as much as we can get, but we have to temper all of that with all of the mechanisms around reimbursement. And we're still at the we're towards the end of coming up with all of the recommendations regarding certification. And in fact, we're already seeing that we can start some reimbursement to some of the doulas through some of the programs in a different way. We have a few different pathways that we're using here in the state of Connecticut. And so I'm still learning. We haven't been given the green light exactly to go ahead with whatever the cost, not the cost, but whatever rate that we're supposed to get in the actual reimbursement to the doulas for certification. We're on our way. And so I'm still learning. But I'm very grateful to be a part of this community now and to be able to get all of the insight and all of the wisdom from you all.
Yeah, thanks, Cynthia. There's also been a little change of topic towards can other communities access early relational health training for other doula programs? And I wonder, Twyla, if you can talk a little bit about how this is available then to others.
It's an excellent question. So we're in the process of figuring out when we're going to do our next big conference. It's not happening in 2025. We're bringing a lot of community-based doulas together for several convenings between now and then. So we're going to wait till 2026. That said, I woke up this morning, David, thinking, so when are we going to do a training institute? Because we still need to do that. So this is something I'm definitely considering to provide access for folks to have training for early relational health, as well as mental health first aid training. So those two things I'm very committed to providing because we recognize the major challenges that are being faced at a national level, very much so in all communities around mental health and attachment, early relational health, nurturing connections, all of that, however you want to put it, we have a lot of issues in this country. So we have to do our best to make sure that folks who are boots on the ground and are it's easier for them to connect to community members, they speak the same language, they have the same experience, that they're armed with these tools. So this is something that we're definitely looking to do. Many of you on the call will probably hear from us because it's going to be important that we do have partners as we build something like this out. I would love to have the ability to do some of this virtually as well as in person, and not having to take on a whole conference in the process. So this is something you're going to hear more about in the coming weeks and months. Thank you.
Thanks, Twyla. It gives you a chance to sort of imagine the future, right? As to what's possible and what's needed and what's important, especially in this moment in time, since so much emphasis is going on about connection, about countering loneliness, about maternal well-being and birth outcomes and community building efforts. And that
I'll add one
relational
more little
message.
thing, if it's okay. I mean, Vivek Murthy
Please.
talked about loneliness. And to be fair, I think of my own pregnancies. I think of my friends, my family's pregnancies. When you're pregnant, I don't think I felt a point in time, even though I have tons of people who love me, I don't think I felt more lonely, right? Because you're the only one in your body. You're navigating that process. So having the ability to connect with others and to connect with your doula who's going to be there with you doing that great counter pressure and talking you through it, through every wave, every contraction, someone who you can connect to, who has been through that process, right? I don't think there's anything more valuable than that other than arming them with these extra tools, right? Because then they come in and they know how to best support you. So yeah, I mean, if the Surgeon General's talking about it, everywhere I turn, I hear him talking about it. We need better connection, right? And I think this is one way to do that. Thank you for letting me interrupt briefly, David.
That's not an interruption, that's an addition and adding that whole concept, starting out of the gate with connection and social connection and networking from the start of pregnancy and those first months becomes a sort of a new way of operating, for way of being with others, and countering the huge number, the survey numbers about young families that are lonely and isolated and disconnected and don't have anyone they can trust, that this focused effort about nurture connection and certainly the doula contribution in that space is, we think, game-changing and really important to elevate. There's another question that's come in that I'm really curious how many of you might respond to this. And the question is, since only 50% of the doulas were familiar with the term early relational health, how do you feel that that's important about the strategic messaging and about the various approaches and how we might think about the message that gets carried about nurture connection, early relational health, and its meaningfulness to your community? What are people's thoughts? Hoda, you want to start first?
I was going to say, I'd like to hear from Hoda.
Yeah.
Yeah, it's a really good point, and it's come up a lot as we were thinking about the curriculum. Actually, the first module was entitled Nurture Connection, and that seemed to resonate more with some of the people that we spoke with during the focused interviews as well as the focus groups. We also interchangeably used early relational health so that they could see that connection to the greater movement that's taking place. We also spoke a lot about feeling safe, seen, heard, and helped, which we coined from Dr. Barbara Stroud. So we referred to it in a lot of different ways, and in the different examples of ways of being, so that it was kind of like this embodied understanding, and tried to connect it with sort of the language that's being used out there right now in the early relational health, nurture connection world, and others, so that, again, the doulas could feel a part of this larger movement, that they were very much using the same tools. So did we pin down a specific term that resonated the most with the doulas? No, and I don't know that there is one, because I think in different communities it's different, and in different languages it's different, and that's the beauty about being relational. It's instinctual, and it's part of being human, and we call it different things in different languages. So
that's a strong point across our nurture connection networks. We talk about nurturance, we talk about connection, we talk about relational health, we talk about relational connections. It's the concept, it's the criticalness of connections to counter isolation. Call it what you like, but don't forget the criticalness of the healing opportunity and the critical importance for the well-being of all of us, and especially for the youngest, around those connections. And not forgetting, connections are the beginning of healings, because they open up conversation. And isolation, loneliness, and silence of trauma or challenges and difficulties in and of itself can be really mitigated by having authentic conversations and authentic connections. That becomes really important. Others want to reflect on this
David,
idea about
yeah,
name?
I would like to, because we encountered this in thinking about policy. And when we went to go think about state policies, we almost had to do a disclaimer, and we certainly had to remind ourselves that it didn't have to be called an early relational health policy in order to be a policy that supported early relational health. In fact, we don't have a program. We don't have a piece of legislation. We don't have we have that agenda that I showed you across all those areas. How are we training the workforce? How are we getting models implemented? How are we supporting high-performing medical home? Where's the fit of infant early childhood and maternal parental mental health? That all the way, and all undergirded with an equity lens, and thinking all the way over into the child welfare system in terms of the context of the healing that you just mentioned, and overthrowing the way that things are. So I think what's less important, it's less important that everyone understand the term, and really important that we hear it in many different ways and reflect it back, as Hoda said. And so that's true at the individual training level, but it's also true at the policy level. So, there are states that are doing things they're not calling early relational health, but they are cataloged in our state early relational health policy report.
Thanks, Kay. Cynthia, do you have any reflections or thoughts? Or Dana?
I would say, and I know that we've talked about this, David, where The languaging was very new to me, but as I was sitting in different meetings that we were having, and I said, huh, this this is familiar. Wait, I kind of know this. And I understand what everybody is saying about not necessarily having to use those exact terms, but also I think it's important. I'm realizing that it's important, especially for our communities of doulas, to recognize what it means when they hear these terms, because language changes and it becomes very it gets difficult in order to navigate, right, in order to know that you are part of a bigger community. And so I think that there is real importance in getting to know that, and I'm looking forward to being able to do that here in Connecticut.
Well, this has been a really rich conversation today. I'm really thankful for, first of all that you've come and listened to us, and also to the panelists themselves for your different perspectives around this good work. And I'm really inviting all of you that are listening to join our join our network. Go to our website, sign up if you choose, and you'll receive a monthly newsletter, but also you get to see what's emergent around this space. This conversation, as well as some of the answers to the questions, will be posted on our Nurture Connection website. And as we're finishing up, we do have a questionnaire, an evaluation question that we'd like each of you to take a few minutes to fill out, if you could. But again, I'm really thankful to all of that have attended, and to our panelists, and again to the the Early Childhood Funders Collaborative, as well as to the Early Relational Funding Community, as well as to our partnerships with Health Connect One and with others. So thanks so much. And the evaluation questions will pop up in your browser as the webinar ends. If you could take the last few minutes of this session to fill that out, that would be really valuable. So blessings to all. Have a good afternoon. Thanks again.